Hello everyone. On behalf of Sahyadri Hospital, Hadapsar, we welcome you to this session on breast cancer. Breast cancer is a big problem in our country. It makes up almost 14% of cases that we see of new cancers every year. And in 2022, it was estimated that almost 2 lakh new women were diagnosed with breast cancer. The problem is not so much the burden, it's the way that people do not have access to care. And we also have a lack of awareness, which leads to a very late diagnosis. Breast cancer is a disease which can be completely cured if it can be diagnosed in its early stages, especially 1 and 2. And today I am joined by my colleagues. We work as a team at Sahyadri, and it is also well known that a cancer patient needs all disciplines for treatment, be it a surgical oncologist, be it a radiation oncologist, or a medical oncologist. And the best decisions that come out for any patient towards cure are when a common decision is taken amongst a team and we come up with some sort of plan or consensus for the patient. I would like to introduce the team that I work with, and on my left-hand side is Dr. Srinivas Kulkarni. He is a DNB medical oncology and he is almost 5 years post degree. On my right-hand side is Dr. Sanjay MH. He is a radiation oncologist and has over 10 years of experience. And on my extreme right is Dr. Joy Ghosh. He is our surgeon. He has done an MCH in surgical oncology from the Tata Hospital, and also has about 10 years of experience. So I would like to turn over to Dr. Joy, and he will briefly tell us about a case of breast cancer which we have all treated recently, and we'll see how we proceeded with the management and gave the best outcomes to the patient.
Hello, I'm Dr. Joy Ghosh. I'm a surgical oncologist. We are a team working at Sahyadri Hospitals, Hadapsar. And today we'll discuss regarding a case of breast cancer recently treated by the entire team. So I'll move on to the case presentation and we'll discuss the details of the case with the team. So I recently saw a patient, 65 years of age, healthy lady without any other problems, no diabetes, no hypertension. She herself noticed a lump in her left breast when she was examining herself, maybe during the bath, I'm not sure. But the patient then decided to seek medical treatment, and then she came to a surgeon and thought that she could get examined. So when I examined the patient, I found that she has a lump in the left breast, and when we look at the breast during examination, we look at the quadrants. So what does a quadrant mean? The breast is divided into 4 different parts, and each quadrant we label as the upper inner or the upper outer. This makes our understanding of the patient's tumor easy, and it also gives us a standardization in which everybody can understand what the patient is suffering from. So going forward, we also like to do some tests. We also at the same time examine the axilla or the underarm to check whether there are any swellings in the underarm which can be due to the lymph nodes which are affected by breast cancer. So moving forward with the discussion, I'd like to ask my colleague Dr. Srinivas that when such a patient presents to us in the OPD, what is the next step that you want to go further with the investigations of the patient?
Namaste. Myself Dr. Srinivas Kulkarni. I am working as a medical oncologist in Sahyadri group of hospitals. I work predominantly at Hadapsar unit, but also caters my services at other units as well. So while approaching such patients, especially when we are dealing with the patients above the age of 60, we need to rule out malignancy as a cause of the tumor or cause of the lump in the first place. So while approaching such patients, we need to keep in mind only one thing. We have to do triple assessment. What does it mean by triple assessment? It simply means that first assessment is a thorough clinical examination by a clinician or the doctor to which you have already shown. Second, if the doctor suspects that it is suggestive of some kind of pathology, we need to undergo imaging, and that imaging is commonly in the form of X-rays of the breast, which is called as mammography, and sonomammography, which is nothing but the sonography of the breast as well as the axilla. And the third component of this triple assessment is basically tissue diagnosis, and it completes a triple assessment. When we say a tissue diagnosis, it simply means taking out a small piece from that particular tumor, not only from the breast, but if indicated from the axilla as well. So when we do physical examination by clinician, when we do imaging either in the form of mammography or sonomammography, and lastly a tissue biopsy or a core needle biopsy, it completes a triple assessment for the evaluation of the breast tumors.
Right. So, as highlighted by Dr. Srinivas, let's keep this sequence in mind that first the examination by the clinician has to be done. So, your doctor has to examine you and understand whether this tumor or the lump is suspicious for cancer. The second thing that unfortunately we face, that a tissue diagnosis is performed before the mammography or sonography, which is the wrong way to do it. You always have to insist to your doctor that a mammography along with a sonography of the breast should be done, and preferably by someone who is experienced in doing the breast sonography and breast radiology. So if you can achieve this, then a picture of the breast as well as a good idea as to what the lump is like can be obtained. Once you get this, the third step and the final step in the diagnosis is a tissue diagnosis, which again you have to insist with your doctor that preferably do a biopsy. How is a biopsy different? A biopsy removes a small piece of that lump and gives it to examination to the pathologist. They can give you a lot more details than a small needle test, which is otherwise known as a FNAC. So keep these two words in mind, that a biopsy is always better than a FNAC, and insist that if it is possible to do a biopsy.
So basically, we had all these tests done for this particular patient, and we found that the mammography showed a 2 centimeter tumor in the left upper quadrant and outer quadrant of the breast, and it was extremely small, and the armpit did not show up anything either on the mammo or the sono. In such early tumors, there is always a question of what to do next. So the biopsy, as Dr. Joy mentioned, was done, and it revealed an invasive ductal carcinoma, which is breast cancer. And we also do certain tests known as receptor tests. Estrogen, progesterone, and HER2 receptors are commonly looked for. What these tell us is the behavior of the patient later on and at present. So whether there is a need to give chemo or targeted therapy, there are certain good types of IHC, there are certain aggressive types of IHC. So these are very important when making decisions of surgery first or some sort of intravenous treatment before the surgery. So the patient turned out to be ER positive, PR positive, that is estrogen and progesterone receptor positive, and HER2 negative.
Right. So as Madam rightly pointed out, the three parameters we look at in the biopsy are this ER, PR, and HER2, which indicate the aggressiveness of this cancer and how do we treat this and the plan of treatment. So once we have got the diagnosis, we also usually need to perform something called a staging investigation, in which we understand whether this cancer has spread from the breast to any other part of the body. We know that cancers are likely to spread even in early stages, although the chances are less. However, this needs to be an investigation which is done for all patients to make sure that there is no other suspicious tumor in the remaining parts of the body. A simple scan is enough. So commonly performed scans you might have heard are CT scans or PET scans to complete this investigation that tells us that the cancer is localized to the breast and not gone anywhere else. So when this patient comes to us with this kind of a report, if the scans are negative, generally the recommendation is going to be surgery first. When we operate this patient, we are going to look at a few aspects, and those aspects I'll be discussing with you regarding the plan of surgery. So when we consider the surgical aspects of this case, there are two options available, which are the first two options we discussed with the patient. One is breast conservative surgery, in which case only the lump is removed along with a margin of tissue where the cancer is clear, and we assess the underarm or the axilla at the same time. We remove some lymph nodes and check them whether the spread has happened to that area. This is called a breast conservative surgery. Now, when we do this surgery, we have to counsel the patient that this is a safe surgery in terms of lower chances of recurrence, but you always have to remember that these patients are going to require radiation, which is a treatment given after the surgery is complete. Without radiation, the concept of doing just a lumpectomy is not safe. And hence, this has to be discussed with the patient prior to the surgery itself, that both these treatments are a must if you're going to conserve the breast. The other option for the patient is something called a mastectomy, in which we remove the entire breast and the chest wall becomes a flat chest wall. There are some options of reconstruction also available when a mastectomy is performed, and those reconstruction options can be discussed with the patient when they are in the clinic. So these are the two main treatment modalities when surgery is concerned. So after this surgery, now when the report comes, the patient's next question is going to be, what is the next further treatment and do I require chemotherapy? So I'll ask Dr. Srinivas to answer this question.
So in a given clinical scenario, 65 years old postmenopausal lady with left-sided breast tumor operated with surgery of breast conservation surgery with axillary lymph node dissection, and we have come to know that it is basically a small 2 centimeter tumor with axillary lymph node negative. It is a common myth that all breast cancer patients need chemotherapy, but especially in such scenarios when the patient is having ER/PR positivity, axillary lymph node negative status and smaller tumor, such subset of patient can be spared well of the chemotherapy, and these are the very well established candidates for only hormonal therapy. But in a given situation, as the patient has undergone only breast conservation surgery, radiation is a must. So then the question comes, she has been operated for left-sided breast cancer. Is radiation safe on the left side as the heart is situated on the left side? Yes, I would request our radiation oncologist Dr. Sanjay to address this issue.
नमस्कार, मैं डॉक्टर संजय हुनगुनमठ, लीड रेडिएशन oncologist, सह्याद्री ग्रुप of hospitals. So as Srinivas just said, it's a left-sided breast cancer, very small tumor, 2 centimeter tumor which is operated, node negative, not planning to give chemotherapy. So it's a very good prognosis because ER/PR, estrogen, progesterone is also positive. So such patients in early breast cancer, now we have reduced our radiation doses. We used to treat for 15 days. Now we are doing it only for 5 days. This is called fast forward. It's a fast forward is the name of the protocol we do, where we treat only the breast, lymph nodes are dissected, node negative, so only breast for 5 days. So we'll be done with that. And the idea, the rationale behind giving radiation for such patients is because whenever breast conservation surgery is done, the name itself suggests BCT, breast conservation therapy, which is breast conservation surgery followed by radiation. So that completes the entire treatment and also prevents the local recurrence almost to 40 to 50% in such patients. So we have planned for this patient 5 days of radiation to the left-sided breast cancer, to the left breast tissue. So basically the problem which we face as radiation oncologist when we're treating left-sided cancers are, see, she is elderly, number one, and it is left-sided, the proximity to the heart is always there. So whenever we radiate such patients, so the dose to the heart cannot be controlled. So now newer modalities have come, like, people used to do IMRT, intensity modulated treatment, VMAT and all. But now the simplest thing which we follow in our clinics, and we have that advanced techniques to do in Sahyadatri Hospital here, is something called deep inspiratory breath hold, DIBH, which is a very novel way of treating breast cancers, where patient holds the breath for 15 to 20 seconds and only in that period the radiation beam is on. And whenever she releases her breath, drops her breath, the radiation is off. So it's deep inspiratory breath hold treatment, which we are doing it on tomotherapy, which is a new latest advanced machine with SGIT. So it's called Vital Hold. So that's the name of the machine what we have. It's an excellent machine. It is very simplified way of understanding when to hold the breath. Patient is educated, trained 2 or 3 days prior treatment, how to hold the breath and when to release the breath. And then she easily follows those based on those color coding and color panels. Coaching is there, which patients understands and then holds the breath and releases the breath, and only that time the beam is on. So it's an automated technique, probably automated software which we have, which is not there anywhere. This is the first in Asia which Sahyadatri Hospital has got it.
So thank you all for listening. What we discussed today was an elderly lady with early breast cancer, and luckily she could get away with a very small surgery called a breast conserving surgery. And she also received not chemo but only hormonal therapy, which we would consider for at least 5 years. And of course, the surgery was followed by radiation therapy. As she's a stage 1 disease, her chances of cure are extremely high, and she's likely to be cured to the tune of 95 to 96% of cases. So with that, we conclude our first case discussion. Thank you again.